Hi, this is Dr. Bowden. We're here again, going to talk now about our seventh class, and we're going to talk about as if you're doing your first case. You can use this exactly like I told you from the very beginning, that you can go through and just use it, play the video, stop it, go do the part, come back to the video if you want. But remember before you do this that you should be going over the steps with the tech and the circulator of exactly what you're going to do. And the technician's handout that you can paste on the wall or paste on your phaco machine has all of the instruments to lay out. It has all of the steps that you need. And so just review those instruments with the tech, make sure they know what's what and what they're called, and you should be ready to go. So the first step to begin with is just prep and drape. And normally what we do is have them give you gloves. Now, see, we don't use gowns or anything when we're on missions. We just have the tech give us our gloves, make sure we're sitting in a good ergonomic position. Then I'll take a bit of gauze, and with the gauze, I'll wipe off the eye to get off the betadine that we've used to prep the eye, because the drape won't stick if the betadine is there. So next what we'll do is remove the paper. I like to do that myself because it gets to be a mess sometimes if they try and do it and then hand it to you. So I use the Q-tip to open the eye, and then we'll open the drape and put it on our special drape holder that we have. It's just made out of 1/2-inch PVC, and you can make one like it. It just tucks up underneath the arms of the patient, tucks up forward up into their armpits. Then we use little clips from the Dollar Tree from the dollar store, and we can use that to help tighten it, get it nice and tight. And then she's showing you that you look up underneath there to double check that you got that drape in a proper position. And you can actually see the patient's nose, and when you can do that, that means that everything is nice and clear. The drape is not on the nose and covering it up, so he can breathe well. He's ready to go. You're ready to go. So now I like to pray with the patients, and when I do, I just pray that God will just bless the operation, that everything will work fine. And then we go ahead and open up the drape using the Westcott scissors that she's just given me there. And once the drape's open, then we're ready to go to start doing the actual surgery. So once we've done that and put the speculum in, then we're going to have her, or have whoever, the tech, do the what I call the big wet of the cornea, because the eye's been closed. There's been a lot going on. You do a big squirt to help wash away all that extra stuff that's been underneath the eyelids, and it's been now had the drape on top of it. So you want to have that all nice and clean, ready to go. Paracentesis now. So the paracenteses you'll put in, and like I told you before, use the blade flat parallel to the iris, and you can just push using your pickups and go in proper depth, whatever you want to do. I went in a little far with that one. I don't need to necessarily for the this one, because we're doing it with the phaco machine. So this side I did okay. We didn't go all the way in on it. So once the paracentesis is done, then we're ready to put in your lidocaine. You can use your lidocaine first because normally you're not going to be doing a block, although I always do a block on missions. You'll insert the yellow. Now, if you're going to use trypan, you would put that in also before the yellow just to help you, but you don't really need it on these small incisions. So put in the yellow, go through one of the paracenteses and inject, make sure it's going until the stuff comes back out. That means you got a nice deep chamber. You got a pressure of around 90. Don't worry about central retinal artery occlusion, and you're ready to go to start your peritomy. So you'll do the peritomy. The peritomy itself is very simple. You just grab on the side of your dominant hand, and you'll make the incision through the conjunctiva, through tenons, and you can use the pickups to help hold things out of the way, and use the Westcotts to go to 1 o'clock, then down to about 45-degree angle, just basically to get into the cul-de-sac to make sure that you can see. Now, there's a little bit of tenons on there that you may be able to tell, so we want to clean that off a little bit, but I didn't use the took knife in this case. So the took and cautery are what's next. So I'm just going to take the cautery and paint with it. I'm actually using the tip of the cautery there, and you can see I'm pushing back the tenon some with that. So that's a nice little trick. You don't actually have to have that step in there with the took, but if it just won't come loose, you just got to stop and go ahead and use the took. So I'm trying to get this area white. I'm trying to get it nice and clean so there's no blood, particularly around the area near where the incision is going to be. I want to get the whole area nice and clean so that I have plenty of room to do the surgery. and I can see to do what I need to. Now remember, you can do the conjunctiva also if you have to, and see I'm holding it there with that Tenon's handle. I've got that in a good place there. So now we're going to still continue holding on to it, and we're going to dry with a Q-tip. So I use the Q-tip to help make the area ready. So I get everything ready so that I can get the incision made properly. I can see exactly what to do. First step is the vertical incision with the crescent. So to do that, what you do is turn the crescent blade upside down, and I mark the high point first. That's going to be 1.5 to 2 millimeters from the limbus. I look at the size of the cataract, and that's what I was showing you there. Is this a big cataract? No, not so big. So I can use a fairly normal type of incision. I like to do the frown if I can. Remember, it's more straight if it's a big and hard cataract and you're going limbus to limbus. Now comes the improve the groove. So you turn the blade over, and we just use the tip of it, the bevel. We're at a 45-degree angle to the sclera. So just going on to the depth, into the depth of the bevel, and that's all that you have to do here in order to get that prepared so that you always have a good, consistent opening. So now we're going to extend to the side and use this for the main incision. This is going to base the width again on the type of lens. So if you need to extend the wound, you can do that. But basically, you're doing just little hand movements, wiggle and squirm, I say, and you're twisting your fingers to move that. And then you're cutting as you're pulling, as you're moving it. You can't just push against that tissue or it just won't work. I've got my good left hand there that's holding the Tenon's handle, and I'm using that as counter traction because you always have to have something. If you notice, I'm pulling left with it, I'm pushing right with the blade, and I'm into the cornea now, and you'll see that as I'm in the cornea, it's a whole lot easier to cut there. Wow, that just cuts right across. It's a lot simpler. The blade, remember, is flat on the sclera. Everything is perfect now. We've got that part done, and we're ready to do the slit or the keratome. We'll use the slit, and we're going to enter the eye now. And so we'll take the keratome and turn it sideways and enter the incision, go in the incision all the way up to the where you had made it with the curve with the crescent. And now we're just cutting to the right and to the left. And remember, I'm showing you there, you want to be sure and go straight from the limbus, straight back to the edge of the incision, and that's what I'm going to show you on this side too, straight down. So going from the limbus down to the straight edge or the final end of the incision that's on the sclera. Now we'll do the can opener capsulorhexis. So I use a cystotome and go in and make an opening and just follow it. Remember, you go from good lens to cut lens. So the first one, of course, is just a cut. After that, you're going from the uncut to the cut, and you're working all the way around. It's hard to kind of tell which way, but starting here, you can really see I'm in the uncut area going to the cut part already, and I'm going all the way around. Nice little circle there. Don't want to make it too big. Want it to be just the right size to get the lens out. But if it's too big, you won't be able to have much left there to hold the lens back. So once the can opener is done, then we'll do the hydrodissection. The hydrodissection is the important part, especially in dark, hard lenses. Now, this one isn't that big a lens, that hard, so I'm going to do about 4 little injections with the hydrodissection. That frees the lens up completely, and then we're ready to rotate the lens out. So when we rotate the lens out, there's a lot of different ways of doing it, but if you can, just kind of press on the lens and turn it, try and make it go horizontally. Remember, if it doesn't spin, you can't win. So you spin it out into the anterior chamber, sometimes get underneath it a little bit there to help lift it up, and that'll also help you as you push the iris back. So it's already into the anterior chamber now. So now we're going to remove the lens, and you can put yellow underneath it. That's a good idea if you have to. And that's what I'm showing you, but watch what I actually do on this next one when I'm removing it. So I've got the cannula in there, and I've already put in a little bit of yellow, but watch what I'm doing. I'm grabbing there at 6 o'clock, and look, I'm just putting posterior pressure with that cannula and pressure with my pickups, and the lens just came out. What does that mean? That means that I didn't have to use the irrigating vectus. But that's good. We didn't need to do it because I made the wound just the right size. Everything was just right. And sometimes you can actually get it to do that. It's really nice when it does. You don't have to use that instrument. It saves a little bit of time. So now we're going to take out the extra cortex. That's the part where we just add fluid first into the eye with our irrigating hand pieces. The irrigating one goes in, the aspiration just puts posterior pressure on, and you'll see that I'm able to get some of the stuff out, but not all of it, but you'll see I get some. And then what I'll do is go back to normal with the cortex removal. Now this cortex removal, I'm going to leave the whole length of it in there just so you'll get an idea of the time that it takes. It doesn't take long at all. It doesn't take you long normally with your single piece IA instrument, but with these bimanuals, it may take a little bit longer. But the beauty of the bimanual is you maintain the anterior chamber just as if you were working in a phaco and doing it with the single piece. But as you work around and you remember you're doing both centripetal and radial grasping of that cortex, getting it into the metal, getting it out, sucking it out, and you just kind of work your way around and see what's necessary to do. Remember, you can see little triangles of cortex that are coming. Be sure not to grab capsule if you can help doing that. But once you've got most everything done that you can with the one hand, then what you want to do is see if you need to switch to the other hand and get that little bit that's underneath the other hand piece. So here I am getting the last little pieces on that way, and then I'm working there, trying to get everything all freed up. You can see how nice it works, and you can also, of course, get underneath the posterior portion of the anterior capsule to clean it up the same way that you normally would with your normal IA. So now I'm switching hands just to get that last little bit. Now the irrigation's coming in on the left in your picture on my right hand, but now we're going to go in there and get that last little bit of cortex that was underneath over there and see if we can't get all of the pieces of cortex. And look, there's a pretty good piece that was left still over there. So you definitely do need to look for that as you're doing the surgery. And then look, I'm getting the 12 o'clock cortex or trying to get those last little bubbles out of there. And that's got it nice and clean for the cortical cleanup. Everything's ready now to go on. So we instill the green in order to put in the lens, so the green being the Provisc. So I'm going to put that in and expand the bag, make it big enough so that I can put in the new lens that we're going to put in. We verify the power of the lens and then we insert it. Now here I'm taking it out of the container and I just lay it on the eye. You don't have to worry about doing that. Use your second or your lens inserter like I like to use, put the haptic between the jaws of it, grab it in the middle, and insert it. Now, look, I'm using the McPherson's to rotate the eye, but that's only because I'm about to use the McPherson's again. Grab right there to help keep that lens from slipping out, because it tends to sometimes do that. Then I switch my McPherson's over to the other side, grasp on the very end of the haptic. That's what I'm going to try and do, and try and push it in to the eye and do that special maneuver I taught you where you go in past the iris with the haptic, turn your hand up 90 degrees, just let go, it goes in good place. Then you can position it perfectly with the pickups there, the McPherson's. So now we're ready to rotate the lens and get it in the proper position. It doesn't have to really be moved. It was in a pretty good position, but if you need to knock off some of the extra cortex that might be in there or get the haptics wherever you want them in a particular position, that's what you can do. And you need to use the Kugelin type. Sinski will work also, but remember on a PMMA, it won't do anything. But on these acrylic lenses and silicone lenses, it'll work great. So now we take out the green. So when I'm teaching, I always say we got to put it in, we got to take it back out. Now we're taking back out the green. And one of the things that you can remember as you're taking out the green is that you need to go and push on the lens. And as you push on the lens, it'll help make that viscoelastic come from behind the lens. And it will help you a lot there to be able to get in there and get all of it from around the edges. You get all of the green stuff out. You can also lift up the edge of the lens and go underneath it if you need to try and get in there. And also sometimes I'll save that to the end to kind of polish the capsule a little bit once the lens is in position, and then I can know that I'm safe doing that. But basically the idea is you're trying to remove all the green, all the viscoelastic from the eye, trying to prevent the post-op pressure rise. And it's really pretty straightforward. It's not any different than what you do with the IA when you're doing the phaco, but it's just that you're using two instruments. And you can find maybe a little piece of capsule or cortex or something that you need to remove. So now we'll move on to the hydration of the paracentesis. And I like to do that. That creates edema in the cornea so that that edema keeps the fluid from coming out. And it maintains the pressure in the eye, maintains exactly what you want to have for a pressure. And once I've got that in there, I'll check the pressure just with that same cannula and kind of check and see how good is the eye. And I'm kind of checking there, see if there's any leaks. And sometimes you might need to, as I did in this case, there was a little bit of blood that had gotten in there, so I kind of flushed it out. And of course, I put in a bubble. I didn't necessarily intend to, but you can. Remember, bubbles are gone in a day to two. Some places, some people like to put those in at the very end anyway, always. Then we put the antibiotic in the eye, and the antibiotic is there to help prevent infection. And it's just a simple little squirt of some Vigamox that I put into the eye, and that helps make sure that there's no post-op infection. And so then we put the patch on, patch and ointment, and that takes care of it. And here we are showing that the lid, the speculum is out, and we're ready to go. So I've shown you a whole big case there. It didn't take that long. You should be able to do everything now. You should know all the steps, and you're ready to go. Thanks.